Well, good morning or good afternoon. We're so pleased to have you join us today. We have about 55 or so of you in with us live right now. We'll give folks just another minute before we officially kick off. And welcome all to our webinar titled Understanding Eating Disorders During the Perinatal Period. We're also going to be talking about policy implications and, of course, resources for treatment and support. And it's our pleasure to be partnering with the National Eating Disorder Association and to be introducing a guest speaker in just a moment. We can move on to the next slide. So my name is Joy Burkhardt. I'm the Executive Director and CEO of the Policy Center for Maternal Mental Health. Our next slide will go over our mission and our vision. So our mission is to close gaps in maternal mental health care. And you might be asking, well, why eating disorders? And you can imagine that there is a gap in detecting and treating eating disorders during the perinatal period. All of us have just begun to scratch the surface on so many issues in the wide range of maternal mental health disorders and substance use disorders. So very pleased to be addressing eating disorders today. Our vision is that all pregnant and postpartum women and mothers have the ability to access standardized evidence-based maternal mental health care from providers and also community-based organizations that they respect and trust. And we center mothers, as you can see in this image, in all that we do, but really support providers, policymakers, payers, and other partners like philanthropy and researchers in helping us close gaps in maternal mental health care. Next slide. It's my pleasure now to get to introduce Dr. Doreen Marshall, who's a psychologist. She'll tell you just a little bit more about her work, but we're so pleased that she's joining us today from NEDA, and she serves as the Chief Executive Officer. So, Dr. Marshall, over to you. And I'm sorry, let me also just let everyone know that we will have time for questions and answers. We'll also be talking about policy implications at the end of today's session. So please do use the Q&A feature in Zoom to ask your own questions, and we will bring those up after Dr. Marshall's presentation. Now over to you.
Great. Thank you, Joy. And it's a pleasure to be here with you. And it's been such a great partnership planning this webinar. So as Joy said, I'm Doreen Marshall. I'm a psychologist by training and the Chief Executive Officer of the National Eating Disorders Association. If you're not familiar with our work at NEDA, we are focused on meeting the needs of individuals and families impacted by eating disorders. And we have a particular focus on changing the way that eating disorders are recognized, understood, and treated. So we spend a lot of time talking about early intervention and really trying to help people get connected to care sooner. And I'm going to say more about that through this presentation. I think particularly when we think about the audience we're speaking about today, the maternal mental health bucket, we think about women that may be in different phases when it comes to an eating disorder. So during these years, some of what we see is new onset, where someone has maybe had what we think of as some disordered eating, but nothing that kind of made it to a clinical level of diagnosis. And then the maternal years, pregnancy, kind of that perinatal period does tend to kind of trigger or involve more a development of a disorder. The other thing we see is that there are folks who have had eating disorders in the past, may have entered a period of recovery, and there's something about entering pregnancy and postpartum that maybe kind of restarts or continues something that started much earlier in their life. So I'm going to be addressing kind of all of that today, but I did want to say part of my background coming into this presentation, well, I've been at NEDA for 2 years and spent a lot of my career in the nonprofit space. I've also, I had a clinical practice and saw many women at this life stage navigating all sorts of stressors that made them vulnerable to mental health disorders across the spectrum. eating disorders being one, but also anxiety, depression, substance use disorder. And we're going to talk about co-occurrence today as well. Okay, so with that, next slide, please. You can go to the next one. Okay, as we start this presentation, we want everyone to prioritize self-care. You may be coming to this presentation with your own lived experience or having supported someone in your life with an eating disorder. So just know that the content may stir up some feelings, and certainly prioritize taking care of yourself. Uh, we're going to focus on a few different things today. The first half of this presentation is going to focus on just what you need to know about eating disorders, particularly in this life stage. And then the second half will be focused more on resources, support, a little bit about NEDA, and certainly we're going to talk about policy implications. Next slide, please. Okay, so our goals for today are to help you learn about the signs of recognizing an eating disorder. When we think about the maternal years, we know that the most a study that was looked at about 2 million data points came up with about 4% of women that are pregnant will experience an eating disorder during that period, during their pregnancy and postpartum uh, period. So 4% of all pregnant women. And when we looked at just kind of how that fits in the big picture, there was more diagnosis of anorexia and binge eating disorder than there was of bulimia in these years. So we're going to talk about the signs of recognizing signs across the eating disorders, but to also recognize within the postpartum and pregnancy years that we do tend to see more anorexia and binge eating disorder than we do bulimia. Um, we're also today going to talk about how you can have a conversation if you're concerned about someone, kind of some do's and don'ts about how to approach this and encourage help seeking. And then, of course, we want to share lots of resources with you that we have at NEDA. Okay, next slide, please. One of the things we spend a lot of time talking about at NEDA is this idea of early detection and treatment. So someone who their eating disorder is recognized early within the first 3 years of onset, and that they're connected to treatment, it greatly improves treatment outcomes. But we know that for some people, this period can go years. One of the things I was sharing with someone recently, a story about a patient who um, had what I would think of as subclinical disordered eating throughout her life. That she was somebody who influenced, like most of us have been, by diet culture and kind of a thin ideal. Had struggled with her body image and had at times engaged in dieting, but never her eating disorder never made it to the point of a clinical diagnosis. And so she had her first child, and that pregnancy, she did experience some postpartum anxiety. But for the most part, the eating disorder didn't change. Or I should say, her disordered eating didn't change. And it wasn't until she had her second pregnancy that she found herself, just her disordered eating had really reached a level of clinical significance. And she talked about how it just consumed her thoughts, fear about gaining weight, fear about weighing too much. Um, but she never, her body, her BMI, she never dropped off what would be concerning to her physician. So she spent her whole pregnancy with what I would consider a full-blown eating disorder that was not on the radar of anybody. And it wasn't until she was postpartum that she actually sought help. So I say all of that because I think what often happens is that clinically these can kind of be under the radar. And it's really important that we engage in things like screening to meet that early detection goal, because otherwise people may not present in a way that that leads us to think they have an eating disorder. One of the most common misperceptions about eating disorders is that the person is clinically underweight when they present with an eating disorder. And we know that that's only true for about 6% of people with eating disorders are medically underweight, which means the other 94% are presenting in what we think of as average size bodies or higher weight bodies. Um, but that's not what most people think about when they think about eating disorders. So, this idea of screening and early detection connections to treatment is really important, but it means we have to get ahead of it. We have to be proactive and ask. And one way to do that is to learn the facts, to learn about eating disorders, to learn what the signs of an eating disorder may be, so that you can take that extra step. And certainly that has policy implications when we think about um, kind of where efforts around screening. We're going to talk about what that looks like in a clinical setting a little later, and some of the policy implications around things like billing and that. Next slide, please. Okay, so before we dive in, I'd like you to take a moment and just think about when you think of someone who has an eating disorder, kind of what comes to mind. I already shared a fact with you about most people with eating disorders are not clinically underweight. But to think about, what comes to mind for you, and also to think about what you think might contribute to an eating disorder. So just take a minute, reflect on that. You can share if you'd like in the chat about that, or if you want to drop in any information or just make a note to yourself. I think it's helpful for us to think about what we think in terms of eating disorders, because I do think most people, the bias or the stereotype is that a person with an eating disorder will be young, white, thin, and affluent. And we know that eating disorders do not discriminate. They go across the age span, across the lifespan. Certainly, men and women can experience eating disorders, and they come in all sizes and shapes. So there's no one type or one person that has an eating disorder. They also don't discriminate in terms of race and ethnicity. In fact, we know that people who do not fit that stereotype of being young, white, and thin are often missed when it comes to diagnosing eating disorders. Okay, so hopefully you've taken a minute to a little self-reflection. Let's go to the next slide, please. So as I just mentioned, eating disorders can affect people from all walks of life. And we know that 30 million people, nearly 30 million people, will be affected by eating disorders at some point in their lifetime. This is a large number of people when we think about how many people we come across in our day-to-day life that may be impacted by an eating disorder. We also know, so we have a screening tool at the National Eating Disorders Association. We have roughly 110, 115,000 people take that tool annually. And what we started asking folks last year was kind of whether being a new parent or an expectant mother was part of their experience. And 2% of the people who took that screening tool indicated that they were either a new parent or expectant mother. So that's something for us to know, that even something like taking an eating disorder screening, we do see a number of people within the maternal years, but also currently pregnant or newly postpartum that are coming to our site to get a risk screening. And that, just to give you a sense of, that would be when we think about the number of people that identify in the maternal years, it's actually 89% of the women or the people that come to our screening are between the ages of 13 and 44. So just to give you a sense of, these are years where people are often at risk for an eating disorder, either developing one, having one reoccur, or relapse from an earlier eating disorder. or like I mentioned earlier, this subclinical disordered eating that may not develop into a full eating disorder until there's other risk factors involved. Okay, next slide, please. Okay, so these are real life-threatening illnesses. What a lot of people don't know is that the eating disorders are the second most deadly mental health disorder behind opioid use disorders. So mortality, they come in second, and the majority of people who die from eating disorders die from either some physical consequence of the eating disorder, so physical damage to their body, from being either chronically underweight or malnourished from a restrictive eating disorder, or GI damage. The other leading cause of death connected to people in the eating disorder community is suicide. So we see second most deadly disorder behind opioid use disorder for mental health disorders, but also high risk of suicide in this group as well. A question I get asked a lot is, well, how do I know if something is an eating disorder or not? And what I tell people is that as psychologists, when we diagnose any mental health concern, one of the things that we look at, in addition to the assessments we have that ask about specific behaviors and experiences, we also think about, well, how much of this particular disorder or syndrome is impacting the person's day-to-day life. So, when we think about that, a person with a diagnosable eating disorder, what you will find is that their mindset is consumed, that they are very focused on um, what they're eating, when there's meal times, body image and body dissatisfaction. There's this kind of, it takes so much of their energy and focus, and a lot of their life planning, including whether they associate with other people, whether they engage in social events. A lot of their life planning is structured around the eating disorder. And so we think about looking at severe impact of functioning in major areas of their life. And so, many people fall in this, what I think of as subclinical, but we know that that also can contribute to risk of a full diagnosable eating disorder. And are also subclinical can be very damaging over years to one's body. When we think about why eating disorders happen, there's no one cause, but it's a combination of biological, psychological, and sociocultural risk factors. So, like many other mental health concerns, it's not one risk factor that kind of predicts that. It's more this kind of intersection of multiple risk factors that come together in an individual who has these vulnerabilities, and the intersection between what's happening, their environment or social cultural pressures, psychological mindset. Certainly we see more rigid thinking in folks with eating disorders, a more significant need for control or internal locus of control. So these are things that can contribute to risk. Next slide, please. Okay. So these are some facts we share with people around eating disorders. I've highlighted a few of them already, but the few I want to dive into on this slide are that eating disorders are not a choice. These are very much mental health disorders that also have physical consequences for folks, but they're not willful, and they are very much an illness like other physical illnesses we experience. What a lot of people will do is when I talk with parents and others, they'll say, I just don't understand why they just won't eat, or why they won't just change the way they interact with food, why they won't just have confidence in the way they look. They look great. They'll say things like that. And what we have to remember is that this is not a choice for the person, that the mindset is one that they are really kind of preoccupied with this thinking. Eating disorders also intersect with other mental health disorders, anxiety being a big one. So anxiety, obsessive compulsive disorder, depression, substance use disorder, we see these alongside eating disorders, and in a good number of the people experiencing eating disorders are also experiencing something else. The day-to-day impact on their lives is enormous, and even when people are very secretive about it or mask what is happening, the day-to-day impact, we see lots of isolation. These are disorders that thrive in secrecy. And so one of the signs we look for is somebody who one of the changes in their behavior is withdrawal, or they stop engaging with folks socially. The other thing I do want to highlight on this list is that recovery is possible. That in the world of eating disorder recovery, there are folks who make a full recovery and do not re-experience an eating disorder. There are folks who recovery is much more of a lifelong process, and similar to the way people experience depression. There are some folks who have one depressive episode and never have another depressive episode. And then there are lots of folks who have multiple depressive episodes throughout their life. And so the recovery or the management of that, just like the recovery or management of an eating disorder, is something we think of much more the way we think of chronic illness, where someone is, continually maintaining treatment. Uh, they may be on medication, for example. So, but recovery is possible. I think what recovery looks like for folks does differ. Next slide, please. Okay, so we're going to talk a little bit about the different kinds. You probably have heard about most of these. What I would encourage you to think about with eating disorders is that mostly these are what we think of as restrictive disorders. So that even when in a disorder such as binge eating disorder, there can also be a restrictive component where the person is limiting their consumption of food or their calorie intake, and that the restriction is what ends up triggering a binge. That is the case for many people with binge eating disorder. But what we should remember is that these disorders differ. And so anorexia is a disorder that involves a severe restriction. And what we see is weight loss or an inappropriate weight gain, particularly for children based on their development. In pregnant women, this can also look like kind of a lack of gaining weight that's expected during someone's pregnancy or during the course of pregnancy. It can also be difficulties maintaining weight that's expected for somebody's height and stature. And what we also see it accompanying with it is body image concerns. So if I were a physician screening the people in my OBGYN practice, I would pay attention if someone is talking a lot about concerns about their body. I would also pay attention to the weight maintenance that's expected through pregnancy, and also weight increases. And if I saw things that were unusual, that could be a sign of anorexia. Bulimia involves a cycle of binge eating followed by what we think of as compensatory behaviors. So they are behaviors such as vomiting, fasting, excessive exercise, using laxative or diuretics or other medication to rid the body of after consuming food. Binge eating disorder is when someone is consuming large amounts of food in very short periods of time, often rapidly, often in secret, past the point of their hunger cues. So past the point of being full, they're often not doing it in response to hunger cues. And those people who experience binge eating disorder can also be accompanied by a sense of shame, guilt, or despair. Something we call OSFED is other specified feeding or eating disorder. It's a category that was used to describe individuals that may engage in eating disorder behaviors, but it doesn't meet the full criteria for any one disorder, but still creates a lot of impairment and distress for someone. And then there's something called ARFID, or avoidant restrictive food intake disorder, which is a new categorization of something that was referred to as feeding disorders previously. what we see with ARFID is that often it intersects with texture sensitivity, fear of eating, or fear of consequence of eating, like choking. Sometimes it can follow a traumatic experience like choking or vomiting in public. And we see this particularly in younger people, though ARFID can occur throughout the lifespan. But particularly in younger people, we may see ARFID develop in reaction to something that caused kind of great anxiety for them around food consumption. There's also some people refer to people with ARFID as being like super tasters. So there's like a texture or sensory connection to it for some people. What's different about ARFID is it doesn't typically have weight concerns associated with it or body image concerns. So the person is restricting, but not in relationship to body image. And then another category would be disordered eating. That's something we call orthorexia, which is one of the types where someone is engaging in excessive healthy eating, excessive exercise, or really with an over focus on health. Okay, next slide, please. So we talked about risk factors, and just really quickly, I just want to hit a couple of the ones that fit in these different categories. Biological risk factors can be having a close relative with an eating disorder or another mental health condition, having type 1 diabetes, or having a personal history of dieting can fit in the biological things. What we know is that um, when someone is restricting eating, their brains are malnourished, and sometimes that can set them up for additional risk. Psychological risk factors involve having another mental health condition, such as depression, anxiety, or substance use disorders, having a perfectionistic tendencies or difficulty with impulse control, having a lack of cognitive flexibility where they have a very rigid mindset, which often is connected to perfectionism. And then sociocultural risk factors are things like experiencing weight stigma or discrimination based on weight, internalization of a thin ideal body, um, higher levels of body dissatisfaction, or experiencing social cultural trauma. Okay, next slide, please. So now we just want to familiar with some of the warning signs. We're looking primarily for a change in eating behaviors. For all mental health disorders, what I tell people is that, the biggest thing is to look for a change. But particularly with eating disorders, we're looking for a change. So somebody who starts avoiding meal times or gatherings around meals, someone who's eating in secrecy, someone who's skipping meals. So start to see a change in eating behavior. You may also see someone who's only consuming certain groups of food or certain textures of food. We see this with ARFID, but also with other eating disorders where there's kind of an overrepresented representation of certain foods or textures and lack of diversity in what they're consuming. The person may be very focused on flaws in appearance or frequently checking flaws in appearance for flaws in appearance. Isolation and secrecy is certainly a big behavioral warning sign, mood swings, and then excessive exercise. Like I mentioned, these are all things that we see in folks behaviorally when they might be experiencing an eating disorder. Next slide, please. Emotional, we hit some of these already, but certainly we see a preoccupation with body size and shape or a primary concern around weight loss, dieting, and controlling their food. Accompanied with a feeling of out of control or shame when eating, often when eating even just kind of what we would think of as a typical meal or a usual meal, that consumption may also be they may label it as feeling out of control or feeling shame. Frequently experiencing low self-esteem and then fears of choking or vomiting or really anxiety around gaining weight is also one of the emotional warning signs. Next slide, please. Physical warning signs, you may notice someone's experiencing weight fluctuations, both up and down. So changes in weight that go in both directions. They might complain of GI issues, stomach aches, acid reflux. They may also have difficulty concentrating and sleeping and or experience dizziness when standing, periods of dizziness throughout the day. They may also have issues with dental, skin, hair, or nail health, which can also be connected to malnutrition or lack of nutrients. Um, you know, Part of the reason we share these is because when someone has developed physical signs, that sometimes is an indicator that the illness is further along. And so we don't want you to wait if you start to see any of these signs develop for the person to get help. Okay. Next slide, please. Okay. So here are some of the complications of disordered eating during pregnancy. And while we've hit upon many of these, some of the additional ones in terms of risk for a pregnant person can be premature birth, complications in labor, certainly difficulties nursing, and postpartum depression. And what I often say to people is the thing that may start an eating disorder may be different from the thing that perpetuates an eating disorder. So it can become this where someone has started engaging in disordered eating behaviors, but then they're so malnourished that they're also having other things, experiencing other physical symptoms where it's uncomfortable to eat, for example, or they start to develop cardiac irregularities as a result of having been, experience this nutritional, often electrolyte imbalance. Risks for the baby, these are probably not surprising to anyone, but certainly there are significant risks when a mother has engaged in disordered eating throughout the pregnancy, risk to both the mother and the baby. Um, you can scan for more information. I can see the links are being dropped in as well in the chat for more information about this on our website. Okay, next slide, please. Um, this is just how these different disorders might lead to complications during pregnancy. Anorexia, based on what we discussed, this is what we talked about. The person is not gaining weight or they're underweight um, versus what's expected. And then with anorexia, we also see an increased risk of low birth weight in the child and subsequent infant health problems. Certainly bulimia is when we see these kind of chemical or electrolyte imbalances, cardiac irregularities, risk of dehydration, which, as you know, is of significant concern when someone is pregnant. Bulimia is we tend to see these complications develop alongside of bulimia during pregnancy. And then binge eating disorder, it's often linked to weight gain, but alongside that, there can be a higher risk of high blood pressure and gestational diabetes. Okay, next slide, please. Okay, so we're going to talk a little bit about treatment recommendations and guidelines, recognizing that this is an emerging area of study. Unfortunately, most of the research we have in the eating disorder field focuses on young women and not women in the maternal years or pregnancy, although we are seeing more research occur. These are some of the treatment recommendations that are out there, just knowing that this is an evolving area of study. Next slide. Okay, so certainly screening is important, and we recommend that screening starts as early as the first appointment, and to not be afraid to ask directly about patterns of eating, any weight or body image concerns that they have. Often when women are pregnant, this is a primary concern of somebody who's experienced an eating disorder or at risk, is that they're a primary concern maybe whether what their body is going to look like pregnant versus their health or health of the baby. There are validated screening tools. Those are something called the SCOFF. Most of these you can find on various websites. We have a screening tool on our website that is anonymous and confident. It's anonymous and confidential, and they can take it for free. So, if I had a patient who was concerned about developing an eating disorder, I might point them to taking that screening tool, and then using that as a stepping point to talk with their health provider. Of course, and this is probably not surprising, to keep the dialogue open, to ask open-ended questions, and to not assume that someone is not concerned about their weight or body image based on the body they're in. Conversely, to not assume in any direction. Um, looking for red flags. So somebody who is experiencing a lot of physical symptoms very early in their pregnancy, and then, for example, some of those persist and don't seem their body is not adjusting to being pregnant, but this is more of a behavioral thing. So somebody, for example, who's purging, while women often get sick, nauseous early in pregnancy, and that's not an uncommon report, to pay a little more attention if someone is talking about vomiting throughout their pregnancy. While we know what happens to some, it can also be an indicator, for example, that an eating disorder exists. And then to consider menstrual history as an early screening cue. So, what we hear, particularly when people have had dramatic changes in their weight as a result of an eating disorder, they may have delayed menses or delayed onset of their menses. They may have lots of skipped period, difficulty with fertility. This can all be connected to an eating disorder. So, asking these questions about history, particularly if this is a new patient, is really important. Okay, next slide, please. You want to certainly be supportive and allow for a lot of open dialogue. If you're not going to be seeing this person on a regular basis, you could also make a mental health referral. Certainly, to someone that has experience with eating disorders is important. To normalize conversations around changing body image and pregnancy weight gain. Sometimes saying, a lot of women have fears about changes to their body during pregnancy. I'm wondering if you're having fears about that. Just really opening up that dialogue and letting them share what they're going to share. Certainly, some of our role is to educate and share, particularly about the effects of malnutrition during pregnancy and postpartum, effects on the developing child as well. And then there are pregnancy specific support groups for eating disorders, and so it can be helpful for someone to be referred to one that is focused specifically on pregnancy or postpartum. Okay, next slide, please. The medical side of this, obviously being sensitive around weight checks. Some people with eating disorders may request what we think of as a blind weight check, or they do not want to be informed of their weight. It's part of their recovery process. So being sensitive to that some may ask not to be made aware of their weight. Certainly you can record it for your charts if you're a physician or provider, but they may not want to be told. And certainly, we should refrain from comments that may impact the person who's at risk for an eating disorder negatively. Of course, screening for complications and adding eating disorders to the list of potential complications when you are screening and noticing complications in a pregnancy to at least allow for the possibility that eating disorders may be part of this experience for this person. They are often very secretive around it, and it may not show up as a person being underweight or having weight loss. So just being mindful of that as you screen that eating disorders may be part of what's contributing to the complications. Labs, certainly labs with people with eating disorders are important, but they can also be a window into what's happening, particularly when we see mineral or nutrient deficiencies or labs where electrolytes and other things are fluctuating. Other things on this list, I would just say, I think it can be important for someone who is gaining weight during their pregnancy and has a fear about that to use psychoeducation, but also to provide context. So to let them know that bodies differ and that there's a range of weights that women in pregnancy gain, and that some of this has to do with one's own biology, but giving them some context around the expected weight gain with pregnancy can help. And then just being vigilant for reemergence of purging behaviors. And sometimes this can be also being mindful of other behaviors or other physical symptoms that go along with purging. Things like chronic sore throat, or problems with their teeth or dental enamel, um, you know, bruising on their hands sometimes can be an indicator that someone is forcibly um, vomiting. So just being mindful that there could be a reemergence of purging behaviors for somebody who hasn't purged in years, and that there can be physical signs for that. Okay, next slide, please. Okay. We talked about blind weighing, but just recognizing that, nutritional counseling, people with eating disorders often work with registered dietitians, even outside of the perinatal years. So recognizing that that may be part of a person's treatment and overall comprehensive support is also having them receive nutrition counseling. Um, and looking for somebody, a dietitian that's experienced with both the perinatal experience but also eating disorders. Unfortunately, most providers do not receive a lot of education about eating disorders. So looking for someone who's done some additional training or has additional certification in these areas can be really helpful. And then to avoid overly focusing on the numbers and emphasize kind of fetal growth and balanced nutrition instead. And when we did this in the beginning, when we did this exercise about like checking your own bias, I, I'm awful my I'm often minded that people often say we make toss away comments. We're all part of kind of this culture that promotes a certain body type as being ideal. And so making sure we're not commenting on somebody's changes in body in a way that may further their stigma or their fear of asking for help. Okay, next slide, please. Okay. And then, I would just say being culturally responsive and recognizing that one of the standards of care for treatment of eating disorders is what we think of as family-based therapy. While that has shown most of the evidence for folks who are younger and in their families of origin, it can also be helpful to include a family or partner, recognizing that that may be defined differently depending on who is supporting the person that is pregnant, to consider how culture plays a role here, and how it may also, their birth plan may be affected by things like malnutrition or complications if they're experiencing other medical risks. To not wait to bring in other providers, whether that's a behavioral health provider, a nutritionist or registered dietitian, or other health providers that can support. And then to make sure that coordination of care is key. So if the person is already seeing a provider, to make sure that we're seeing good comprehensive coordination of care, communication with other providers, sharing of treatment goals. Okay, next slide, please. In the interest of time, I'm just going to move quickly through these next few, just recognizing we have tons of information on our website. I think just in having these are caring conversations where you're direct, where you connect the person to help or suggest help, where you do it privately, and also plan ahead of what you might say. These are hard conversations to have. And I think it's most helpful to ground in what you're noticing, particularly around distress or anxiety or preoccupation with food or body image, to say, hey, I've noticed, this is the third or fourth time you've mentioned that you're concerned about gaining weight when you're pregnant. And I just want to hear more about that for you because I'm concerned that it's taking up a lot of your mental energy and I'm worried about you. Just kind of finding ways to gently open the conversation, but then to be direct. Like, I'm wondering if this is something that might put you at risk for an eating disorder. And why don't we see if we can get some more information about that or talk to somebody who knows more? Next slide, please. Okay. Obviously you want to plan for relapse risk postpartum. Many women, experience, they will have even increased concerns after they've had the baby about, I'm doing air quotes here, getting back to whatever they think is an ideal body. And so just being aware that sometimes that can lead someone to engage in disordered eating behaviors postpartum, or there can be a risk for relapse, alongside other mental health concerns like postpartum depression and anxiety. We should be affirming of breastfeeding decisions, regardless of what they are, whether a person chooses to solely breastfeed, to supplement, or to strictly use formula. We should be supportive of those decisions. And then certainly helping, recognizing the person may need more support as they're adjusting to their post-birth body. Okay, next slide, please. Okay, obviously, this is probably not surprising. You want to avoid shame, guilt, um, offering advice or simple solutions, or invalidating what they're experiencing. You may not think they have any reason to be concerned, but obviously it's a concern for them. And then certainly we don't want you to ignore the problem. I think most people tend to take a wait and see approach, and we would argue against that, particularly because we know the longer these go untreated, the more entrenched these illnesses tend to get. Okay, next slide, please. To recognize that the first attempt at help may not be met, may not be welcomed by the person. They may feel exposed. They may get very defensive. Um, and to acknowledge, like, well, it's okay. Like, if you don't want to talk about this now, I want you to know I probably will ask again, but that this is something I'm going to support you through and be with you through. I don't think any differently of you for having these concerns. Um, at the minimum, if you're concerned about someone, they should get a medical checkup, because that will give us some indication. So blood work, for example, or just a thorough physical checkup can really give us a window into what's happening. And then I would also say, let the person to some degree lead, as long as it leads to help. So there may be pieces of this they're willing to start with. They may be willing to go see a registered dietitian before going to see a psychologist, and to start where they start, but also to make sure they're getting care that's eating disorder informed from someone who can provide that. Okay, next slide, please. Okay. Quickly talk about resources, because I want to make sure we have plenty of time for questions. Next slide. Okay, so our screening tool on our website was developed by researchers. It screens for eating disorder risk. And as I mentioned previously, it's anonymous, confidential. The person doesn't have to leave any contact information. When they take the screening tool, they screen at risk or not. And as you might guess, most of the people that find the screening tool on our website do screen at risk. It's around 94%, I believe, of people who take it on our website screen at risk, because they're already looking for eating disorders information when they land on our site. But we are working to extend the reach of that screening tool so that people can find it in other ways. When they screen at risk, then they get resources are shared with them, including a treatment map that has an ability to find resources in their area of people who are eating disorder informed or have a specialty within eating disorders, so that they can find a provider who's equipped to help them. We have in October, we do a national ED screening week where we promote these messages and work with partners on increasing access to screening. So that's something that's coming up, and we'll be sure to make sure you hear about that if you're working with the Policy Center, because it's a big week for us where we really try and raise awareness for screening, but also promote it across settings. Okay, next slide. Okay, we have a resource center, lots of information, stories of lived experience, blogs, low-cost treatment support. If you scan the QR code, you can find it. It's named after a woman who died as a result of her eating disorder, and her family supported the development of it. Next slide. Okay, we do community events across the U.S. We have a campus, excuse me, Campus Warriors program. That's a college-based groups where they raise awareness on campuses about eating disorders. They also work alongside college counseling centers to do awareness events. Some of them do meal support on their campuses. We have care fairs, which are mental health care They're mental health fairs focused with eating disorders alongside other mental health concerns. They're fun events where the recovery community comes out. And often it's the first time somebody shows up visibly talking about their eating disorder. We have people share stories and their lived experience, speakers, and things like that. And then we run awareness campaigns, the screening week, one in October, also Eating Disorder Awareness Week, end of February. And we always welcome volunteers. So if you're interested in getting involved with us, scan the QR code or reach out to one of us at NEDA. Okay, next slide, please. Okay, so we're going to get into Q&A, but I would encourage you, one way of making the information stick is to think about something that you didn't know that you learned during this presentation, and one way you'll apply the information. It can be talking to someone in your life. I often say it's a good prompt to just say, hey, I attended this presentation today and I learned a lot about eating disorders, and particularly if you're trying to talk to someone about their eating disorder. I'm a parent, and I will say among my kids, one of the best ways to share information with them is to tell them about what I'm learning, and then also to ask them, like, yeah, I wonder if any of your friends might be experiencing this, and see what they say. And then say, have you ever experienced this? Has this ever been a concern of yours? Can be a gentle entryway to getting more information. So think about what you will do with this information from today. We're going to talk about the policy side in a second, but I think it's important to take some of this information with you out in the world. Okay, I think that's probably the end of my slides. Let's see. The survey, of course. We love feedback on this presentation and the info we're sharing. So we ask that you take a few minutes, take a survey to give us feedback on the presentation. You could just do it by scanning that QR code. Okay, and I see it was also just dropped in the webinar chat. Okay, so next slide, I guess, and thanks, of course, Joy, and to the team for having us come on board. If you want to see references, we do have them listed in the presentation itself.
Excellent, Dr. Marshall. We do have some questions in the Q&A feature. And of course, I would love to start with some questions and dialogue with you about some of the practice and policy implications. And also, there's a few things that really stood out to me in your comments and wanted to unpack those with you for just a bit. But I think when you first started out, you just talked about how life-threatening eating disorders can be, and that we're often not thinking about that in the same way in our space, for example, as we might think about overdose or suicide. Can you just remind us one more time the prevalence of I don't know that we have research yet on maternal deaths related to eating disorders during this time frame, but anything else that you can share with us about the mortality rates here?
Yeah, I mean, I think this is really tricky, and what you're highlighting, Joy, is I think some of the challenge we have around data in the eating disorder field, but particularly in this life stage. So when I look at where we have good data in terms of eating disorders, it's more like what I think of as the younger folks, like adolescents and college age. Much more of the research has been done there. I think what I would say is, if you think about 4% of people who are pregnant are going to experience an eating disorder. So if you kind of, expand that out to how many people experience pregnancy throughout a year, and then to recognize that some percentage of those folks will develop physical consequences of some sort. Because I think the challenge is sometimes mortality is a longer tail thing, right? And so if we're seeing someone during their initial their pregnancy and postpartum, for example, the physical health consequences may actually develop over time and not become life-threatening until later. That's not for everybody. The deaths are certainly overrepresented, I think, for anorexia due to the significant malnutrition and other health consequences. But for things like bulimia and binge eating disorder, it tends to have what I think of as a longer tail, meaning that the consequences tend to be chronic And when people experience life-threatening consequences, say GI rupture or something like that, it's usually later in the illness. But anorexia and suicide really represent most of the deaths when it comes to eating disorders.
Yeah, I appreciate that. And for those of you who may be involved in your maternal mortality review committees in your state or perinatal quality collaboratives, your antenna may be going up here as well, whether there's an opportunity to do more work around identification of potential eating disorders in our maternal mortality data. So we have flagged that as a potential takeaway to perhaps talk with our colleagues at the CDC about. Thank you for that. I want to move on to a related question from Marie Laurie about the prevalence of pregnancy-related medical complications, and if you know if there's any data around things like preeclampsia or other related health conditions during pregnancy. And it's okay, Dr. Marshall, if you do not, we can put on our radar to do a literature review as well.
Yeah, I don't have data on that connected to eating disorders, which I'm wondering if that is the question. Certainly
Yeah.
happy to follow up with whatever we can find. I think one of the things I would just say, and I'm thinking back to my own kind of clinical work with women around pregnancy and postpartum, that I think sometimes we see physical symptoms happening, but we don't connect the dots that this is related to an eating disorder. So, if you think of something uh, dizziness or like fainting upon standing. Sometimes that happens when women are dehydrated during the pregnancy, and sometimes that happens because they're dehydrated or they have electrolyte imbalance because of an eating disorder. So, it's kind of, I think what I would say is around the health things is to maybe allow the possibility of an eating disorder to also inform when you're diagnosing and treating other health things that women experience during pregnancy, because I think often eating disorders are not on the radar unless the person is overtly speaking about engaging in disordered eating, or, a lot of times it remains kind of off the radar of OBGYNs particularly. So that doesn't really answer the data question, except to say that I think part of the reason we don't have good data is because sometimes the physical health concerns aren't connected to eating disorders.
Yeah, absolutely. We're working on a mental health history form and going to be using some of the questions that you all have dropped into, actually, it was in an email exchange with us, but adding some of those questions, but you alluded to them, Dr. Marshall, about, do you feel comfortable being weighed? And do you want to discuss your weight? If so, those kinds of things I think are really interesting. And the other comments that you've just raised are really on point. So appreciate that dialogue. Another related question about how things can be masked comes in from Monica in the chat, or Q&A rather. Monica says, I've seen cases where bulimia is masked by pregnancy nausea, and that a patient may purge and not clock it as a disordered behavior. Can you talk a little bit about the potential interplay there, Dr. Marshall?
Yeah, I mean, I think that's a great point. And I was reflecting as you were reading that question on a patient I saw years ago in an outpatient setting. So I was her psychologist, and she was pregnant, and she talked about fainting. And I had known about her eating disorder, but it was so she let me just give you a little more context. She had an eating disorder in her younger years as a teen, bunch of years of remission, pregnant, started talking about fainting. And, for me, because I had that context, I was able to kind of pry a little bit and say, tell me a little more about the fainting, the frequency, and started recognizing that she was re-engaging in purging behavior, and that was part of it. So, I say all of that because I think it behooves us to get curious and because it can be masked. I think that's a great point that the person who asked the question is making, that if we don't have that on our radar, or we're not doing routine screening, we may over attribute it to something else that's transient versus an eating disorder that's becoming more and more entrenched. Um,
Great.
but I think it's just an excellent point that the person is making, that it can often be masked, and we almost have to go in intentional with the idea that things like that can also be an eating disorder. lots of women complain about acid reflux, for example, during pregnancy. But for somebody who has a history of purging, that may take on kind of a more severe form or a different form. So just being really curious. I don't know if that answers the point, but just keeping eating disorders in the realm of possibilities of why something might be happening.
I love that. I love your point about getting curious and asking questions, open-ended questions. And you also said earlier, things like, I won't think anything less of you. Let's see if we can find some more information and get you connected with an expert. Those are just really amazing words that you're using. And we're not surprised because you're a psychologist as well. I also just think the point that you raised earlier, just reminding folks that an eating disorder can happens in 4% of all pregnancies, just helps to normalize and help people know that they're not alone. That's fantastic. We've got another question in chat, and then we'll move into some of our policy conversations. From Nicole. Nicole, another sort of related question. Nicole raises that she has seen clients who have met with lactation specialists who mention weight loss as a part of breastfeeding, and we're wondering if you can talk just a little bit about what's a good way to approach this, because it potentially, again, could be related to an eating disorder, weight loss. You generally covered it already, but anything else you want to cover on that point?
Yeah, I think it's a great point. And I think what I have also seen in the folks I've worked with in the postpartum period is that sometimes the idea that weight loss will occur because breastfeeding or the production and lactation tends to take a lot of energy, caloric expenditure. So sometimes I've heard people say that that's actually a motivation for them around breastfeeding, that they almost want to breastfeed not only because of benefits to the baby, but because, and so then if they have experienced challenges, there can be even more frustration. So, I think it's important to recognize that for some people, the idea of breastfeeding might be tied up into this idea of I'm going to lose weight or lose it quickly. And I said getting curious of asking around motivations for that, but also I think managing expectations, because I think what also happens is that sometimes women aren't consuming enough calories to breastfeed effectively because they're in a weight loss mindset around it, and then they experience lactation difficulties, right? And so if I were a provider working with someone, I would get really curious and ask those questions, and to not assume, right? Like if someone is saying like, oh, I don't have time to eat or something like that, to get curious about that and to use psychoeducation, particularly around breastfeeding and the need for calories to be able to breastfeed and be healthy. Because I think that's the other piece of it. Like the motivation for weight loss, sometimes people just don't consume enough calories to be able to have effective lactation.
Great, thank you. So I want to turn to just some policy and practice related questions, as folks who know the Policy Center well know that we're really interested in behavioral health integration, which means supporting obstetric providers like OBGYNs and midwives starting in pregnancy to detect the range of maternal mental health disorders, also substance use disorder, and of course now eating disorders, really trying to get all of these challenges on the radar, and OB supported in doing this work. So one of the things that we often hear when we do behavioral health integration is sort of the then what. I identify a problem, who do I refer to? And so I wanted to talk a little bit about where folks can find specialists that have received additional training in and supporting eating disorders, and if there's my understanding, Dr. Marshall, is there's not yet a credential, so it's not like a PMHC like there is in maternal mental health care yet. But anything you want to talk about in terms of finding experts?
Yeah, so their credentialing with eating disorders is there's a voluntary credential that's a certified eating disorder specialist, that is done through one of the professional organizations in the eating disorder space. um, it's one thing that people can identify around a provider that may have that background. Certainly, the ones that are on our website may, that's another way to find a provider. But you're right, there's not this kind of state or national credential where like this is a voluntary credential. So I say that meaning people pursue additional training to receive it. What I think I would say, though, is that what's probably more important is to ask questions because there are people who do not pursue credentialing, for example, but do have experience working in the perinatal and in perinatal eating disorder specifically. So I would just ask a lot of questions if I were trying to find a provider about what their experiences are, what their viewpoints are. Um, and the other thing I'll say about certified eating disorder specialists, that is a credential that can be held by behavioral health folks, but also registered dietitians or others may also carry that kind of credential.
Great. And we'll drop that into chat. Thank you for letting us know about that. And that actually is fantastic because then, we're also very much interested in making sure that there are adequate networks of these types of providers, adequate training, and that type of thing so that OBs and others can trust the person that they're referring to is trained. So that volunteer credential is great to learn about. We also talk a little bit about how do we empower and support obstetric providers in doing this work because it can get complicated. My understanding is there is not like a national technical assistance center. Is that an accurate understanding? And then we'll also talk a little bit about billing in just a moment.
Yes, so there is a currently a National Center of Excellence for Eating Disorders, and so within that, certainly one of the populations they serve because it's across the age band. But I'm not aware of one that looks only at the intersection of perinatal and eating disorders. But they kind of focus on provider support in terms of training and things like that. They are federally funded, and we are in a time of administration changes as a result of the current administration. So, but it's the National Center of Excellence for Eating Disorders that's run out of the University of North Carolina.
Yep, thank you for reminding me. There is not a TA center, but a Center of Excellence, which is essentially the same thing. And Shivani, if you don't mind dropping that into chat for us, that would be great. So these are all great resources to make sure that our providers are aware of, and perhaps we can outreach them together. The Resource Center to talk about this period, Dr. Marshall. One thing that we wanted to point out is that right now obstetric providers um, are often paid a flat bundled rate, a flat rate for all of pregnancy once pregnancy is confirmed through the 6-week postpartum visit. And there's some work happening to unbundle at least part of that care, including maternal mental health care, so that OBs can bill for multiple screenings, for example. And some payers will actually already pay for all of these multiple screeners, but OBs and midwives don't know about this. And then also bill for evaluation and management when there's a positive screen. So we're working on identifying those solutions outside of the bundle for all of these screens, including screens and follow-up treatment for eating disorders. So I want to just invite folks, if there's any other questions you have, and I think we do have some more that have popped in, we'll answer those now and wrap up in just a few moments. Okay, great. So patient portals. So any thoughts on, and I think we're really what we're getting at here is there has been a move to screen through patient portals, perhaps in advance of meeting clinic OB meetings or even in behavioral health settings, and this sort of like measurement-based care that might be happening through portals or EMRs, electronic medical records. Have you any thoughts on whether this is working well with eating disorders? I think the general literature in our space with maternal mental health is that women may feel like they can answer more honestly when they're answering remotely versus in person, perhaps like having someone watch them circle questions on a form can feel a little intrusive at times. So that's what we found is generally the case with a great researcher who's been published in Health Affairs. But Dr. Marshall, any other thoughts from you on screening eating disorders in this way?
Yeah, I mean, based on the use of the screening tool we have on our website where people don't have to identify, I mean, what we find is, so we have about 115,000 people take that annually. We've had over 1 million since it's been on the website. And I think you're right, Joy, that there is something about kind of answering those questions and not doing it sitting across from somebody. I think what I would add is that screening is very important and can help someone, be on your radar for an eating disorder that maybe wasn't before. But it's also not the end of the story, right? Like that part of how we understand a person's eating disorder and needs for treatment is related to assessment. So while the use of screening in patient portals is so important, we should follow up. I think that's the piece. Like, and sometimes what I've noticed is sometimes physicians and others with all of the things that they have to do, those kind of the things, the screeners and things that people take within patient portal may not get a thorough kind of follow-up or assessment. And so finding how to do that effectively when you have somebody screening at risk, because I think what's also challenging is knowing kind of what of the eating disorders a person is experiencing. Um, and the screening tools are getting better. Certainly the one we have on our site was researcher developed, but when you think about cultural differences and other things that might inform how someone answers the questions, I think this is what assessment really helps kind of fill in the gaps around.
Great, and that's a helpful comment about screening more generally. I have a follow-up question related to assessment. Have you found that trained non-clinicians, like community health workers, or in our, some cases, perinatal navigators, for example, are they also in a position to do this type of assessment, or do you find that it's really helpful to have a clinician do the assessment?
Yeah, I think that's a really good question. I mean, I think for, payer purposes, there may be a person who needs to be designated based on credential to do the assessment. But when you think about ultimately an assessment is kind of an informed interview. And I think there is a way for other providers to be asking questions that either will inform the situation or will ultimately inform the assessment. So if you think about like, physician practices that have nurses and PAs and residents and others kind of working with them. Um, Sometimes it can be helpful to have someone asking the kinds of questions that get more information for then the provider to know if they have to do a more thorough assessment or not. So I kind of think of it, I don't know if that fully answers your question, Joy. There's nothing that really prevents people from doing the questioning. Like when it comes down to billing and credentialing and who actually can bill for an assessment, that might be different in terms of credential. But we do have, say, registered dietitians assessing for eating disorders as much as we have behavioral health folks assessing for them.
Great. I appreciate that. And I think it's an art and a science, right? And we have found that if there's not a screening tool, it doesn't say that it has to be administered by a clinician, which most don't. It does seem like there is opportunity for non-clinicians to assist with the interview, at least, if not, full assessment, diagnosis, preliminary diagnosis. Another question about psychopharmacology and drug treatments here. Is there anything you have to share on that front?
Nothing specifically, except I would say that just because we know eating disorders intersect with other mental health disorders, it's not uncommon for someone who say is experiencing OCD or anxiety alongside their eating disorder to be treated with an evidence-based medication for that as well. So um, I think part of the challenge, and this is maybe my soapbox, is we need more research to know what's effective around medication for eating disorders specifically. We have some research, but not a ton, and not certainly across the lifespan. And that's always counterbalanced with during the perinatal years, like what someone who's either trying to conceive or is pregnant can take, right? So we just need more research, particularly treating eating disorders using medication. But we do see it happen. the instances I can think about with this are much more around treating the underlying anxiety or other comorbid mental health concern.
That's helpful. One last question. There's some other questions just about general therapy practices, which I think we can follow up offline with those individuals. But one other flag that someone raised is there a link between gestational diabetes and eating disorders? And then also, do you have any data around pregnancy loss because of eating disorders? I think the answer might be no, but again, another important follow-up for infant mortality tracking.
Yeah, I'm not familiar with the data on, or if there is data on gestational diabetes and eating disorders, but we could certainly find that out. I'm not aware of anything that would be kind of comprehensive or conclusive to say about that. I think the second part of your question, though, feels to me, some of what we know puts people at risk for eating disorders. There is a connection between traumatic experiences and eating disorders. And so it would make sense to me that pregnancy loss, particularly, we all have different thresholds for what we experience as trauma. But somebody who had what I think of as a traumatic reaction to pregnancy loss, that can also be one of the risk factors related to developing an eating disorder, experiencing trauma. The research is focused more on adverse childhood experiences and trauma and developing eating disorders. But, as a clinician, I would say I would certainly, if someone was having a lot of traumatic anxiety related to pregnancy loss and they had some other risk factors for eating disorders, I would certainly want to pay attention to that.
That's great. Well, excellent. We're going to go ahead and wrap up. I did want to share a few questions about whether the recording will be available. Will we get links to these resources, or do we need to pull them out quickly through chat? We'll pull these resources out and share them with the recording and the slides post the webinar within 48 hours. And with that, we'll go ahead and wrap up with a few reminders of upcoming events. We'll move on to the next slide. We wanted to share with folks that our annual forum, where we talk about all things emerging in the field of maternal mental health, and perhaps we do a special session on eating disorders, is going to happen March 17th through 18th. It will be web-based like it has in the past. You can find out more on our website at that forum link to save the date. And our next slide. We also do a maternal mental health or perinatal mental health 101 training quarterly. That's coming up in partnership with our friends at Postpartum Support International on September 4th. Again, you can find this on our events and training page as well. Next slide. One more save the date. We're also doing a perinatal substance use disorder 101 webinar quarterly as well, or maternal substance use disorder, either way. That is October 1st, the next one. Really amazing a quarterly webinar that we invite you to participate in as well. And then lastly, we're just thrilled to be doing this great work with all of you who have joined us live, those of you who are watching the recording, and of course, our partners at NEDA. Thank you so much, Dr. Marshall, for all of your great insights and really starting to lean in to close gaps in the perinatal mental health space. Thanks all, and stay tuned if you're not yet a member of our e-newsletter. We invite you to sign up and learn more about all of these great events and more information on eating disorders as well. Thanks, everybody, and stay cool and enjoy the rest of your summer. Thank you again, Dr. Marshall.
Thanks, Joy. Thanks to your team.